Dr. Knobbe, do you recommend omega-3 supplements? And if so, what is the advised dose? Do you recommend omega-3 supplements?
No, I never.
Oh, I'm sorry.
Flip it off here. Just flip it back, switch up. Yeah, this one.
There you go.
No, I do not recommend omega-3 supplements. I think that we should get the omega-3 exclusively from our diet. The omega-3s are far less likely to peroxidize or oxidize than the omega-6, but I still don't believe that it's healthy to, pull them out and put them into a capsule or a bottle or whatever and leave it sitting around exposed to oxygen and light and all that, and where it's going to oxidize. But secondly, you're never going to help yourself, in my opinion, by just adding omega-3s. What you have to do is get your omega-6s way down, like I talked about. You need to be down in the, around 1% on your omega-6s. So the whole issue about omega-6 to omega-3 ratio, there's only one way to fix it, and it's to get your omega-6 down, and it's got to be really low. And you can do that with just eat like our ancestors in the United States. Before we had any seed oils, they we calculated this, and I'm kind of blanking on the numbers exactly, but the omega-6 and omega-3 are extremely low, like approximately 1.7 grams or less of omega-6 and around 0.74 grams of omega-3. So we need tiny, tiny amounts of these omega-3 and omega-6 fats. You can get them all from just grass-fed beef, and I think you're best off getting them from good, healthy, pasture-raised animals or fish. But I would not recommend taking any kinds of omega-3 supplements ever. That's my opinion.
Next one for Chris Webster. This is a great one here. Chris, if cost was not an object, how would you design the perfect nutritional study?
Yeah, it's
the question. Or is it for you?
The other Chris.
Yeah, I think that's. I suppose institutions would maybe be helpful, where you can 100% control what you're feeding people for very long periods of time. But then that brings in the whole ethical issues. So if you could control what you're giving people for long periods of time, it might be possible to get really meaningful results out of these randomized controls. I think I don't know the answer to that.
We need to all become human lab rats, and then we could just do it, right? Like that, right? All right. Dr. Ali, question for you is, how would a primary care doctor best use the insulin-glucagon ratio that you spoke of in practice, and how does it compare with like A1C testing, et cetera?
So insulin-glucagon ratios are not in practice at all. Measuring glucagon is a little bit unclear. It's picomolar quantities. So when you compare insulin to glucagon, glucagon is 3 times more powerful on a molar basis. So I myself have not done it. I don't know if there are any research labs that are doing it. But this is a very important aspect for the low-carb community to get into and try to understand how these two vary. And I think the most important thing that I wanted to convey to you is that if insulin is functioning well, glucagon will go down. And if there is insulin resistance, both of them go up simultaneously, and that is bad. How do I design, what do I recommend to a primary care physician? I'm sorry, I don't know that answer.
Maybe focus on the insulin, and the glucagon takes care of itself, kind of thing. Is that what you know?
I guess that's right. If you can show that you have phase 1 insulin response, so like for example, you give a glucose tolerance test and you check your insulin level within 30 minutes, and your insulin level goes way up from a baseline that is very low, like a low carb at less than 5, and then it goes up to 50, then you know that you have preserved phase 1 insulin response. Another thing is just go to Keto Mojo and check your ketone levels with your blood sugar. If your blood sugar is low and your ketone levels are decent, that means you have a fairly stable insulin-glucagon relationship.
Very good. Dr. Knobbe, again, is there any evidence for vegetable oils increasing risk of autoimmune diseases, specifically eye diseases or retinal diseases?
Well, that's a tough question. I think it's not really my area of expertise, but I know that we've had an explosion of autoimmune disease in the last century, and personally, what I do know is that vegetable oils in the gut, especially combined with sugar, seems to be a fantastic mechanism to increase gut permeability, to increase your intestinal permeability, and I think this is a major driver in terms of producing autoimmunity. The other thing, I think of right offhand in terms of this whole scenario, for example, is that some of the toxic aldehydes have been implicated in, for example, in macular degeneration, in inducing autoimmunity. And carboxyethyl pyrrole, for example, which is one of these toxic aldehydes that comes from omega-6 oils, is adducting with proteins in the retina and inducing retinal autoantibodies. For example, it's one of the most well-studied of these toxic aldehydes, at least in relation to macular degeneration. And so they call it CEP, carboxyethyl pyrrole adducts. So this is a significant driver in terms of producing autoimmunity. And that's just one example in the retina. So, and then I believe there's, obviously, if you look at what's happened to our vegetable oil consumption and autoimmunity over the last 100 years, as I said, there is a very strong correlation there. Mm-hmm. But as far as getting into all the different types, I haven't done that.
Okay. Yeah, thank you. This is for Dr. Ali here. If someone is known to have arterial plaque based on the results of a CT angiogram, do any of the other cardiovascular risk factors indicate the extent to which the plaque might be stable versus unstable?
So good question. First of all, coronary artery calcium score, if you do it less than 45 years of age, you don't really know if that is a valid test, because you could have soft plaque that may not have calcified. So the traditional thinking is that soft plaque is a little bit more vulnerable, a calcified plaque is more stable. I don't know if the answer to that is clearly known. There is so much variability in the human body, but somebody asked a question about making the plaque stable with statins. But there is a study that has been done in which not only was calcium score measured, but they did coronary CT angiograms. Coronary CT angiograms are done in which you actually image the whole coronary artery, see how blocked it is. You check soft plaque, you check mixed plaque. And in that study, the patients on statins not only had higher calcified plaque, they had higher mixed plaque, and there was a trend towards having higher soft plaque. So go figure that out as to why that study is not, propounded and looked on by cardiologists as something that, hey, I should reevaluate the data on statins. Wow. I don't know how to evaluate plaque that is about to rupture. I don't think there is any good way to do it.
Another question, Dr. Knobbe, about macular degeneration. What is the current status of any supplements or anything else we can do? Is it all just reduction in omega-6? Is there any kind of other things people can do to help with prevent that?
So there's a very long answer to supplements and macular degeneration. Let me try to summarize that really quickly. So the ARID study, the age-related eye disease study, looked at, which began back in the 90s and followed about 4,000 people. And what they put them on was vitamins EC, beta-carotene, and then zinc and copper. And this was a 5-year study. Now, the thing that's confusing about macular degeneration, it's not like a heart attack or a stroke, like you either have it or you don't. There's categories. And so what they found, though, was, let me put it to you this way. First of all, there's no evidence whatsoever that these supplements in any possible study has ever prevented macular degeneration. That should tell us something. If you're in the earliest stages of macular degeneration, stages 1 and 2, this is like the few drusen in your macula, those patients had no benefit at all from these supplements. If you're in categories 3 and 4, which is category 3 is moderately advanced macular degeneration in both eyes, and category 4 is advanced macular degeneration in one eye, and you took the ARID supplements for 5 years, those people that took the supplements, 20% of them progressed onto more advanced macular degeneration in that 5-year period, whereas those who took placebo, 28% progressed. Okay, the difference between 20% and 28% is 8%. You know what this means? There was only 8% of them benefiting. So what the number needed to treat is 13. In other words, only 1 in 13 people taking the ARID supplement would benefit. Now there's a little more to this. All right, so then Carl O and colleagues in Tennessee, they analyzed they analyzed the ARID's data versus all the different genetic categories, and what they determined was that around 30% of the people across the board who took the ARID supplement would be worse off if they took it. So the bottom line is there's about an 8% chance that you would benefit, about a 30% chance they'll make you worse. Okay, just to finish, then they did the ARIDS 2 study, and there they added in the omega-3 fats, and the second part of that was adding in lutein and zeaxanthin, the carotenoids. And what they found, in the initial results of that, they said no benefit for either one. No benefit for omega-3s, no benefit for lutein and zeaxanthin. And then they reanalyzed all the data again, and they came back and said slight benefit for lutein and zeaxanthin as a supplement. And so here's the thing is, we're missing the point. This is not what we're needing. We haven't isolated what the problem is. The problem is nutrient deficiency and toxicity, right? It all goes back to this diet, that people consuming vegetable oils have extraordinarily higher risk of macular degeneration, and this is what we see.
Wow, that's fascinating. It sounds like they're the statins of the macular degeneration world, the supplements.
Right.
Wow. We've got some questions over here.
Hi, Dr. Knobbe. Benjamin Kuo here was session chair for you at the Ancestral Health Symposium for 2 years in a row, so I'm a bit of a ghost from Christmas past. I'd like to know, since we had Michael Eads up here yesterday, and he talked a lot about the Egyptians and their high rate of heart events, that nobody's going to accuse the Egyptians of having a lot of vegetable oils in their diet. So what gives?
What gives?
Yeah, why is there, in the absence of industrial seed oils in the ancient Egyptian diet, why do you think they had such a high rate of heart disease?
I'll tell you, Ben, I was just educated by Dr. Eads on that as well, and I was actually totally shocked that they apparently had safflower oil, but so I think it made me wonder, and I don't have any answers. I I don't know if we had a lot of data about how many people actually had heart disease, for example, but it makes me think, number one is safflower oil is a horrible, highly polyunsaturated oil. So that's one thing. And with all the wheat in their diet, sounds to me they had a nutrient deficient diet. So that's the perfect. If you're consuming a lot of omega-6 PUFA and you're nutrient deficient in the fat soluble vitamins A, D, and K2, that right there, that's the setup, as far as I'm concerned, for this disease.
Right. Do you also suppose that there's a possibility that we just haven't had the availability of diagnosis for cardiovascular disease prior to maybe about 1900? That people were dying because, from heart issues, it's just that they were not diagnosed, or, that just wasn't, attributed as a cause. Do you suppose that that's also a possibility?
No, I don't really believe that. If you go back and read a lot of the textbooks from the 19th century, I'm telling you, the physicians of the 19th century, their clinical skills make us look pathetic, because we rely on all this technology. We rely on all these labs and MRIs and echocardiograms and EKGs, and they didn't have all that. They used their clinical skills. And no, I do not believe they were missing heart disease. The descriptions of angina, just like, Sir William Osler, 1897, as I mentioned, in 1897, he reviewed 21 years of hospital experience, never seen an MI. And he made it very clear in 1897. He'd seen about 6 cases of angina, chest pain, in 21 years of hospital experience. Now, this is what happened next. I didn't have time to tell you this. In 2010, 13 years later, he reported in London at a meeting he had witnessed an additional 208 cases in that 13-year period between 1897 and 2010 of angina, still not a single MI. So, and what he attributed it to is, he said, I wonder if it's the pressures of modern life. Yes, that's exactly what he said. So I do not believe we had any significant heart disease. These clinicians were extraordinary. Go back, if you pull up the 19th century textbooks, their descriptions of disease is absolutely amazing. And a lot of the ophthalmology textbooks, I just have loads of these. Their descriptions of what you see in the eye, in the retina, from the 1850s forward, will rival anything that we have done. Because we use fundus cameras and we use ocular coherence tomography, and it's just like what the cardiologists would do in their profession. They've got all this technology. But what they had was an ophthalmoscope and their eyes, and they were brilliant clinicians.
Thank you.
Thank you very much.
I have a quick aside for Nadir. Both Dave and I test glucagon and insulin on every test, and we have seen some other data points from other people, including diabetics.
Can you speak up a little bit for us?
Oh, sorry. I said a quick aside for Nadir. Both Dave and I test insulin and glucagon on every test, if you ever want to take a look. And we also have a couple other data points from 2 diabetics and 1 person with a history of heart disease, in case that's of interest. My question is actually for Chris. I'm curious how you came to the conclusion that omega-6 oils cause cellular insulin resistance, and that this will lead to pathological insulin resistance. As Sarah Hallberg mentioned, physiological insulin resistance and pathological insulin resistance is not the same thing. And there are also many, many studies showing that saturated fat will cause cellular insulin resistance, which causes physiological insulin resistance, which is low carbers is kind of necessary. I'm wondering if you've ever seen the work of Peter of Hyperlipid or Fire in a Bottle, or even Michael Eads' presentation from Low Carb Breckenridge. All of this kind of covers the same thing, so I'm wondering how you came to that conclusion.
Well, first of all, are you absolutely certain that these studies that claim that saturated fat is driving insulin resistance had no omega-6? Are they coming from, are they pulling their saturated fat from pastured animals, and they're getting their saturated fat, their polyunsaturated fat at an ancestral level, like 1%. So many of these studies, I have looked study after study where they say, well, it's a high-fat diet, and it's not even described where the fat is coming from. Sometimes you can't even dig it out. And but personally, and I don't know if I'm answering your question, I want to, but personally, the only mechanism that I am aware of that could drive the destruction of cardiolipin in the intermitochondrial membrane, which causes loss of the proton gradient, which is what the electron transport chain depends on, is based on the fact that a high PUFA diet causes oxidation of linoleic acid in the cardiolipin. And then that oxidation of the linoleic acid means that there's a three-dimensional conformational change in the molecule, or it's replaced by docosahexaenoic acid, DHA, or arachidonic acid, AA. And when that is replaced, there's a three-dimensional conformational change in the entire cardiolipin molecule, which can create pores in the intermitochondrial membrane. And this creates a hydrogen proton leak. And that hydrogen proton gradient is what drives the production of ATP. When the hydrogen protons come through the intermitochondrial membrane, ATP synthase is what uses that power to oxidatively phosphorylate ADP to ATP. So this is how we lose energy, and it's very clear that to me, it's described based purely on a high omega-6 PUFA diet.
To answer your question, one of the studies in particular I'm thinking of was a mouse study with a truly low-carb, high-fat diet, where one arm had a high PUFA diet and the other had a high saturated fat diet. And what ended up happening with the high PUFA mice is that they ended up experiencing hypoglycemia and hyperphagia because they were not insulin resistant on a physiological level, so they were not sparing glucose. But again, that is not the same thing as pathological insulin resistance. And if you want any of those studies, I would suggest maybe trying to find Michael Eads. He's here and did a presentation on similar topics about 2 years ago, I think.
Okay, thank you.
Okay, thank you.
Let's. I was going to ask one from here now. Dr. Ali, I'm an ApoE4/4, so both alleles. What are the health markers that I should be monitoring to make sure my brain is functioning as efficiently as possible? And on that, are there resources available that I can utilize to stay on top of the emerging science for ApoE4s?
I'm not an ApoE expert, so I'll put a disclaimer out there. But I think that in my review of literature, the insulin resistance is the primary driver of dementia. So I think ApoE3 or ApoE4 are minor contributors. If you're 4/4, you're probably at greater risk of getting dementia if you get insulin resistance. So a person like that probably has to be very diligent in making sure that their home IRs is good, that their insulin glucagon ratios are good, that they don't have inflammation. In terms of resources, you would have to look on your own. I'm not an expert, so I'm not going to go there.
Okay, thank you. Yeah, go ahead.
This is a question about cardiology. As I was listening to Dr. Brett share, I was trying to listen to every little piece of information, which was super hard. And I think I missed the meaning of those individuals who are hyper responders with a 0 calcium score. So maybe, Dr. Ali, you can tell me what he said, because I missed it, and I would like to know.
So Dr. Brett Scher was talking about person with a 0 calcium score who are lean mass hyper-responders that Dave Feldman has so nicely explained to us.
Yes.
What do you do about them? And I think Dr. Brett Scher's line is that we don't know. And I think that's the right answer. Now, people like me who probably are willing to bet a little bit more say that if you're a lean mass hyperresponder, you have low insulin levels, you don't have any inflammation markers, and if your calcium score is 0, I would like to take my chances and not go on a statin. So that is my position.
Thank you. I'll take it.
One more question, I think, would be good.
Thank you. My question is about, I have to leave here and go home and figure out what to do with this information when I'm taking care of patients. And so my question is really specific about the recommendations that have to do with the use of high-intensity statins. And that's been somewhat of a moving target lately. In the guidelines, they've moved the ASCVD risk score for those patients needing high intensity from 7.5% to 20%. And I'm wondering if you can comment on the data that specifically addresses the patients who have that ASCVD risk score over 20 and any compelling data that might be existing to support the use of high-dose statins.
I don't think there is any data whatsoever to support high-intensity statins. It has been looked on for years. The Ideal trial compared a high-dose Lipitor to a simvastatin dose did not find a mortality benefit. In fact, the people who like to prescribe statins decided to change their message. And the message was, treat risk, not number. So I can take you through data after data, whether it's with Crestor or whether it's with PCSK9 inhibitor. When you're looking at a drug, you want to see dose response. As you increase the dose and as you reduce the LDL cholesterol, you should see a higher magnitude of benefit. That has never been shown in any clinical trial. You can take it a step further. You can say, hey, I am going to take a Crestor trial in which it was primary prevention. What that means is that people had no previous heart disease, no stents, no heart attacks. In this group, they are less likely to die. So I'm going to see what's the degree of benefit. And you would say, okay, the benefit is small. Then you go to somebody who is secondary prevention, has had a heart attack, has had stents. You would say these are higher risk populations, so I should get more benefit. Then you go to a third group, end-stage renal disease, diabetic patients. You should say this group is so much at high risk that reducing their cholesterol should benefit. So when you look at it in Crestor, 3 trials, there is no gradation in benefit. In fact, the end-stage renal disease patients on Crestor did no better whether they were on statins or no. The diabetics did no better whether they were on statins or no in terms of mortality. So anybody arguing for high-intensity statins is just doing it without any good data to back that up.
Thank you so much.
There you go. And on that note, want to just thank all of our presenters here for their great job today. Thank you so much. Let's give them a round of applause.